Great to be in New Orleans. I was born in Mobile, Alabama, but the very first time I came to New Orleans was in 1987. I was in business school on spring break, and a buddy of mine who's the chaplain for the Louisiana legislature now, he lives in Baton Rouge, Rodney Wood, surprised me. It was March, and the Final Four was at the Superdome, and he had tickets to the Final Four, so it was a great memory. Indiana won that on Keith Smart's jumper in the last seconds and to beat Syracuse. So I have fond memories of being in New Orleans, and I've been here several times since then. I want to give a shout out to David Mason and Nelson Hendry, who I've known for almost 20 years. They're great guys, and Jason Green, and then Andrew Head's been helping me on this, so I really appreciate them. Your hosts are great connectors, and I hope you feel welcomed. I also want to thank Cuba because I'm on, as Adrian mentioned, I'm on the board of the ASHP Foundation, and Cuba is one of the biggest sponsors of the ASHP Foundation. We're going to talk about the significance and severity of the healthcare labor shortage, and sadly, I have no relevant financial relationships with any commercial interests, none whatsoever. We're going to learn four things. We're going to get our arms around the healthcare labor shortage problem. We're going to figure out what's driving it, what has caused it. We're going to look at the impact, not only on the healthcare system, but on our society as well. And then we'll take a look at some short-term solutions, approaches that people have tried, and then I'll propose a kind of a long-term path forward. So let's talk about the magnitude of the healthcare labor shortage. How many of you, I'm going to be asking some questions here, so how many of you, show of hands, how many of you have watched more movies because of COVID than you did before? Be honest, come on. I watch a lot of Netflix movies, and I think I've watched almost every possible one about World War II that they have. And I like movies that are based on a true story. I think a lot of you probably like movies based on a true story. And in fact, last weekend I watched Operation Mincemeat. It's on, yeah, some of you have seen that. I saw some people nodding. Colin Firth, you know Colin Firth from 1917, from the Bridget Jones movies, and so many other great movies. He's the star in that one. It's a true story about how the Allies tried to deceive Hitler in World War II to make him think that the Allies were going to invade Greece rather than Sicily, right? And so when you watch this movie, I didn't know anything about it, even though I've kind of studied World War II for many, many years. You know, when you watch a movie like that, you kind of go, wow, I'm curious. I'm going to look that up. I'm going to research that. And you end up with Wikipedia or something, and you find out about a true story. So that's amazing, right? Now, what's even more amazing is when it's based on a true story, and you know the outcome. You know how it ends. But the movie is so captivating, so well done, that you become part of it, and you forget how the ending is, and you feel that sense of suspense. You remember movies like that? So there's a movie, Apollo 13, and in the movie, I love Tom Hanks, and Tom Hanks is in the movie, and he's Jim Lovell, the commander, and in the movie, what's the most famous line? Houston, we have a problem. Now, if you're a serious student of history, you know that actually Jim Lovell did not say, Houston, we have a problem. He said, Houston, we've had a problem. And he was quoting Jack Swigert, the lunar module commander. And Swigert, who's played by Kevin Bacon, by the way, he says, Houston, we've had a problem. Now, how big a problem was it? It was a big problem, a huge problem. It threatened to short-circuit the entire mission and threaten the lives of those astronauts, right? Well, in similar fashion, we have a huge problem in healthcare. This is something I've been beating the drum about, or trying to beat the drum about, for the last half year or so. And these are some of the articles that I've had a chance to write about this issue. It's such a big problem that we really need to think about how to solve it. So I want to say that America as a country is a fantastic marketing country. We are so great at marketing. We're great at branding. We're great. Think about the biggest brands in the world, like Coca-Cola, or Apple, or Nike, or Google, or Kentucky Fried Chicken. Those brands throughout the whole world, if you ever traveled overseas and you see, oh, there's the McDonald's, I feel at home now, okay? Or there's the Coca-Cola. those brands are powerful. So Americans are good at using words to describe things, and then those words can become part of culture. So there's a phrase or a term that was created about the healthcare labor shortage that was created by a professor named Anthony Klotz. And he is, I'm going to go back here. He is actually a professor at Texas A&M's business school, the Mays Business School. And it was called the Great Resignation. That was the term that he came up with. Some of you may have heard of that. Some people are saying now it should be called the Great Attrition. But really what's stuck, what's now part of our culture, is the Great Resignation. And this is a term that was used to describe what he thought, his prediction, which was made in 2020, that in 2021, millions upon millions of Americans would resign from their jobs. They'd quit their jobs in the following year. And he was right. So the U.S. Bureau of Labor Statistics, the BLS, in April of 2021, an all-time record, 4 million people, Americans, quit their jobs. And in subsequent months, we had more record setting. A solid 4 million in July, 4.3 million in August, and 4.4 million in September. Now, what's interesting is in those months, I looked at this in August and September, there were over twice as many open positions available as resignations, and people were not having any part of it. They were going to quit and think about it and wait. Open positions. And over a period of time, those 6 months, April to September of that year, 24 million Americans quit their jobs. Now put that in perspective. Let's put that in perspective. That's 1 out of every 6 workers in the United States resigned from their jobs. It's incredible churn. And the job resignations, as I mentioned, were significant as well. So the Great Resignation was real and very significant. So I want to ask you a question. How many of you are in communities where there are lots of help wanted signs? Retail, fast food chains, pharmacies. We have it in spades where I live. I live in the San Francisco Bay Area, and we cannot get help for so many different employers, right? So many businesses do not have enough people. It's a huge problem. So Jack Kelly, who writes for Forbes, says, we've become a nation of quitters. Think about that. We've become a nation of quitters. Man, that is so un-American. We're not quitters. You watch movies, we don't quit. We always win in the movies, right? We persevere. We don't quit. That's not who we are as Americans. We love Miracle on Ice. We love winning the championship. We love being number one. We love winners. But we become a nation of quitters. That's what Jack Kelly said. So I talked to you about the overall reduction in the workforce and people quitting, right? So let's talk about healthcare. So over 500,000 people left healthcare, about 4% of the workforce, between February of 2020 and September of 2021. 4%. Now, when we talk about healthcare labor shortage and people quitting, oftentimes people want to talk about, and we're going to talk about nurses and another category, but I want to talk to you about a primary care physician shortage just because it's significant, and it relates to the provider status legislation that the pharmacy profession has been pushing for. Primary care physicians, or PCPs, are really important in healthcare. The government says that if there's less than one primary care physician for every 3,500 people, that's a primary care physician shortage area. Or think of it this way, a PCP desert, like a food desert, when you don't have access to fresh, nutritious food. How much of the United States is a PCP desert? 1,200 counties in the United States are PCP deserts. 44 million Americans live in those counties that do not have enough primary care physicians, and over 10 million Medicare beneficiaries are in those places. Now we're going to focus, though, not just on PCPs, we're going to talk about nurses. The nursing shortage is huge. The American Nurses Foundation, or ANF, did a huge survey of almost 12,000 nurses back in January, last 3 weeks of January. These are employed, registered nurses, and they found that 9 out of 10 organizations have a staffing shortage, and over half of those are experiencing what's called a serious staffing shortage. And by serious, that means they're asking nurses to work overtime or double shifts. They're using travel nurses. They're cutting back on access to care because they don't have people. That's what a serious nursing shortage really means. And the average age of nurses has gone up in recent years. Now it's 48 years for those who are employed. For all registered nurses, it's over 50. And it's projected that about 1.1 million nurses are going to retire by 2030. So this train is coming. Also, pharmacy technicians. So I have the privilege of being involved with and supporting the Autonomous Pharmacy Advisory Board. Some of you may have heard about this. This is an industry movement that's led by a group of pharmacy and nursing leaders from some of the biggest systems in the United States. And their mission and vision is to use technology to improve pharmacy care, to use technology to improve the efficiency and the efficacy of medication management across the care continuum. So I was at their meeting in September, last September, in St. Helena, California, which is in the northern part of Napa Valley. So when you think about Napa Valley, you think of wine, and there was wine tasting going on there. But between sips of wine, I asked a question of all these pharmacy leaders. There's about a dozen of them on the board. How many of you are experiencing pharmacy technician shortages or having a difficult time staffing pharmacy technicians? Good, you guys answered the question. That's the question I asked, and you guys immediately raised your hand. That's what they did too. All 12 of them said, I am. We're having problems with that. That's exactly right. It's a huge problem. NCPA, which is for community pharmacies, retail pharmacies that are small, not the large chains, they said, hey, nearly 90% of us can't even find pharmacy technicians. We've almost given up trying to find them. That was in May 2021. And then Walgreens, so talk about the big chains, Walgreens is seeing staffing outages, or shortages rather, across the country, and this is from their Senior Director of External Relations. So, to sum up, hospitals, health systems, retail pharmacies, both large and small, the big chains as well as the community pharmacies, are having a problem getting enough pharmacy technicians. And I'm sure many of you have some pharmacists who are doing some pharmacy technician work. In fact, last week I was at Hilton Head, South Carolina, with that Autonomous Pharmacy Advisory Board, and I asked them that question. How many of you have pharmacists who are having to do pharmacy technician tasks? And every one of them said, I've got some. Not all, but some. We're covering for them. So it's very serious. So let's talk about the causes of the healthcare labor shortage. You know, it's fashionable to say it's COVID. I use COVID as an excuse for all kinds of things, right? I couldn't get to that because of COVID. Or we aren't going to meet because of COVID. We're not going to do whatever because of COVID. It's taking us longer because of COVID. There's some truth that COVID has contributed to the healthcare labor shortage, but I would argue that it is an exacerbation factor, not the primary factor for the healthcare labor shortage. So let's talk about COVID. Huge impact. It's a continuing impact, as you know, with the new variants. And so I want to share with you some statistics here. If you could say, what's the impact in one word? Burnout on people. The impact on people, burnout. Over 3/4 of U.S. employees, not just in healthcare, across the United States, all industries, are currently experiencing worker burnout. Over half say that they're worried about COVID-19. And that's contributing to the burnout. And then about a third are saying there's political issues that have contributed to their burnout. Do I wear a mask or not wear a mask? Do I keep 6 feet or not? Should we meet in person or not? Should we hybrid? Do we Zoom, etc.? All those issues. The things that we naturally like to do, giving a hug to someone, we have to think, wait a minute, is this okay? Think about that, the impact on you and how you relate to different people. It really changes us, and it can cause us a lot of stress having to make those kinds of decisions. Can we go out to this restaurant? Will it be safe there? You probably have asked yourself that question. Can we eat outside? No, I can't go to the movie with you. Those kinds of things you probably have heard. Now I'm going to share with you some pictures of people in healthcare. And as I share with you a handful of pictures, I'm not going to say anything about them. I want you to take a look at these pictures and think, have I seen this picture or these images in my workplace? Ever in the last couple years. And the second thing I want you to think about is, do I know the name of that person? Do I know them? So here we go. I'm going to show you a few pictures. I want to give voice to the challenges that healthcare workers have faced. And I want to quote a woman I know well. Her name is Amanda Arrington. She's the daughter of our next-door neighbors. She's a nurse at the University of Washington. She went to Gonzaga as an undergraduate, got her nursing degree. She's in a cancer or oncology unit. And she's a dear friend of my daughter, Christy, and they grew up together. So here's what she says. As a nurse, COVID-19 has really put a strain on many parts of my life. Work, friends, family, my mental health. The hardest part, though, was this feeling of medical duty and guilt. I felt like I couldn't do anything fun or I would risk the health and safety of my coworkers and immunocompromised patients. I had to be safe and never do anything too risky so I could go to work and take care of my patients. And if I ever did anything seemingly normal, I felt guilty for it because I could be putting people, friends, and patients at risk. The last 2 years have been a constant battle of, am I doing what's best for my patients, and am I doing what's best for myself? Think about her words. Your friends, the people you know who are nurses or technicians or physicians or pharmacists or pharmacy technicians, were dealing with some of these kinds of issues. They were wrestling with these kind of challenges that Amanda articulated so well. And in fact, Amanda's feelings, she's not alone in that. The ANF survey that I mentioned earlier asked this question: in the past 14 days, have you experienced any of the following feelings? Now, they gave them about 25 different feelings, and they were the most ecstatic and positive and happy to the most sad and depressing, etc. These were the top 5. Stressed, 71%. Exhausted, 69%. Frustrated, 69%. Exhausted, 65%. Overwhelmed, 58%. Undervalued, 52%. Now think about this. If you have a friend that came to you and said, hey, Jim, I've been really feeling stressed. I feel really overwhelmed in my job. What would you say to them? Would you say, no problem, buck up, take it easy? You'd probably say, maybe you need to take some time off. Maybe this isn't the right role for you. Maybe you should have a change of scenery. You'd probably suggest something like that as a friend, right? These are the kinds of feelings that nurses, and this is a huge nationwide survey of almost 12,000 nurses, the kind of feelings that they said they are experiencing. Many people were experiencing 2 or 3 of these very negative kind of feelings. And you know, here's a real pointed question. Have you had an extremely stressful, disturbing, or traumatic experience due to COVID-19? Over half of the nurses said they had. Think about that in your workplace. If half of the people you know have experienced a traumatic experience, what kind of culture would that be? Pretty rough. They also asked them, have you experienced any kind of workplace incivility or bullying? And they asked this about, several different groups of people, right? This is staggering. The patients and families, they felt, had bullied them or treated them in an uncivil manner. 57% of the nurses said that. 53% said that about the families. And then you say, well, I'm sure they got good support. They've got great managers, supervisors, very good mentors, counselors, experienced people. Look at what the managers and supervisors in administration, 26% apiece. Nurses are saying, wait a minute, they actually bullied me. They actually treated me poorly. They actually forced me to work another overtime shift. They asked me to work overnight, even though I had worked 16 straight hours already. Pretty rough. Now, pharmacists also have a real challenge, and I think many of you can identify with this. This is data from ASHP. 3/4 of pharmacists' time spent on non-clinical activities. And I mentioned earlier that pharmacists have had to cover for the lack of pharmacy technicians. Many of them are doing pharmacy technician tasks. A lot of this is to do with manual processes, administrative processes that are not patient-centered, that are not very satisfying to pharmacists. And in fact, even before the pandemic, a January survey found that 75% of community pharmacists said they were experiencing burnout before the pandemic. Emotional exhaustion as a driver, depersonalization, and then look at that, reduced personal accomplishment. If you're doing manual tasks, if you're doing mindless tasks, how do you feel like, oh, it's been a great day? That's not a great day. And pharmacists are experiencing that burnout because of that. In addition, there's what's called economists call an externality here. It's not about how we treat them in a hospital or health system or in a retail pharmacy. There are other employers who are competing for people, right? Specifically pharmacy technicians who have kind of the skills that could be very useful for other kind of settings, and they're being paid well. September 2021, Walmart announced a $1 increase to their average starting salaries to $16.40. Amazon, that same month, increased their starting salaries by $1, $18 on average, and they said we're going to hire 125,000 people for transportation and warehousing jobs and other kinds of jobs. 125,000. Amazon and Walmart have fantastic, I checked this out the other day, they have fantastic educational reimbursement programs, very generous. Does your hospital or health system or does your retail pharmacy, do they offer those kinds of things? Probably not. So that's a challenge, and it's helping drive the pharmacy technician shortage for hospitals, health systems, and retail pharmacies. So the biggest issue is the graying of America, a demographic issue. We're getting older as a country, and this is something we need to take a close look at. Gail Walensky, who was head of HCFA under George H.W. Bush, has recently written about this in HFM, and she's absolutely right that their demographic and economic changes have led to the healthcare labor shortage in a big way, and I would say bigger than COVID. The graying of America. So I think we've known about this for some time, so here's some data. Those who are over 65 have grown as a segment of America, reaching 54 million in 2019. 1 out of every 6 Americans are over 65. And then you can see the growth since 2009. Some of you may have seen CMS came out with its National Health Expenditure Report. This was at the end of March. I look at that every year. And the interesting thing about it is it predicts that through 2030, the 65 and above segment of our population is going to grow at an average rate of 2.5%. The segment of our population under 65 will grow at an average rate of 0.2%, 0.2%, basically flat, not growing at all. And as a result, America is going to get a lot more gray, a lot older going forward. Look at this graph. This is the annual percentage change in the U.S. population from 1900 to 2021. The average, if you do the math, is between 1 and 1.5%. We average growth in our population. But if you look at what happened in the last 20 years, we're at less than 1%. And in fact, in 2021, we had an all-time low, the lowest percentage increase in our nation's history for our population, 0.1%. But this trend has been going on for at least 2 decades now. So here's some interesting data. U.S. population, the median age is about 38 in the United States today. And registered nurses who are working, 48, as I mentioned earlier, nurse practitioners almost 44, and pharmacists 41. Okay, here's the deal. When your median age for your profession is higher than the median age for the population, it's a bad sign. It means that the younger population, the younger generations, are not filling the roles of the older generation. That is a warning sign for the United States and for these particular jobs. So let's talk about the impact of the healthcare labor shortage. So there's a downward spiral that is created when you have a shortage and people leave. The ANF survey asked this very important question. Again, remember, this was asked in January. In the next 6 months, do you intend to leave your position? 23% of them said yes. If you do the math, there are 3 million registered nurses working in the United States today. That works out to about 700,000 nurses. Now, if you don't believe that, and you say, no, there's not. They've got to work. They're not going to do that. They're just bluffing. Okay? Incredible Health just came out with a survey. It said 34% of nurses say that they will quit by the end of this year. Elsevier Health said that within the next 2 to 3 years, 47% of clinicians, physicians, and nurses are going to leave their positions. 47%. And McKinsey just came out with a projection that says we're going to have a nursing shortage of 450,000 by 2025. 450,000 by 2025. Those are big numbers. So when people leave, conventional wisdom, if you talk to anyone in HR, or if you've been in HR, why do people leave their jobs? right? The number one reason, it's your boss. Your boss doesn't understand you. You don't feel like they believe in you. They're not developing you. They're not mentoring you. There's no future for you, right? That's the number one reason in general. But the number one reason why the nurses are leaving, they're deciding to leave, insufficient staffing. That is what's causing the problem. Because when people leave, those who are left on the ship have to do more work. And they are working even harder. It's like squeezing a turnip, right? Now, in addition to that, there's this perfect storm. We just talked about the supply is depressed, supply of workers is depressed, but now we have the demand going up. McKinsey did the survey in 2021. They talked to 100 private sector hospitals. And they found out that in 2021, inpatient admissions had already recovered to the 2019 pre-pandemic levels. And then they said, guess what? We are predicting a 4% increase relative to 2019 in 2022. So again, supply is being depressed, the demand is going up. A perfect storm. This is such a bad problem that Cleveland Clinic and HCA both said, you know what, we do want to have a COVID-19 vaccine mandate, but you know, we're going to suspend that because we need people. We've got to keep our doors open and take care of patients. It's not optimal, but this is what we're doing. It was a compromise they had to make, a concession they had to make. So all of this has gotten the attention of hospital CEOs. I was just at a conference last month, the Scottsdale Institute conference, with a whole bunch of CEOs and CFOs and CIOs. And Gene Wood said, he's the head of Atrium Health, he said, look, we're going to have a shortage of physicians, nurses, and technicians for the rest of our working careers. And no one said no. No one disagreed with that statement. It's the number one issue, according to ACHE, for CEOs of hospitals. This is a big statement. That was the first time since 2004 that they had said labor shortage, personnel shortages, rather than financial challenges, is the top issue. And the interesting thing about it is they not only identified the shortage as the top issue, but they actually demonstrated some knowledge of what categories of workers do they have shortage of. Not just the high level. They understood that nursing shortages were the top concern, 94% of them said that. And then technician shortages, including pharmacy technicians, 85%. They are aware that it's a deep problem and it's a big problem. Of course, when you have a shortage, they're thinking, hey, we got to run this operation, right? This hampers our ability to deliver care, it impairs access, and it reduces the revenue for our institution. So it has financial implications, obviously, as well. All right, so now we're going to talk about short-term and long-term solutions for the healthcare labor shortage. You know, when I was growing up, we used to say, call in the National Guard. It was kind of a catchphrase, kind of a joke. In California, it was like, call in the National Guard, there might be an earthquake. Or maybe in the Southeast here, you'd say, call in the National Guard, we have a hurricane. It wasn't something that we would say, you know, it's real. We just kind of like, call in the National Guard. It was kind of a joke. And now in California, we need to call in the National Guard because we have so many wildfires. That's the thing we have to deal with. And so that's exactly what happened. Governors from 19 states, there's the list of them right there, 19 states said, we're going to call the National Guard. We need help. This is a crisis. This is a problem, big societal problem. These 19 states, you see California on there, New York, 5 of the top 10 states in terms of population are among this list of 19. And these 19 account for almost 50% of the population of the United States. There might be 1 or 2 other states, but I was kind of keeping track of this, keeping a tally of how many states are calling the National Guard. What's the problem with calling the National Guard? Is it a good long-term solution? No. They're good people, good, well-intentioned, but are they pharmacists? Are they nurses? Are they pharmacy technicians? No, they're not trained to do that. They can help in some small ways, but really temporarily. It's not a good long-term solution. Here's another solution. Engage in a bidding war. This is the most common. This is the one that we immediately say, well, gosh, if Walmart and Amazon are going to offer more money, or McDonald's are going to offer more money, I want that pharmacy technician. I'm going to engage in a bidding war. I'm going to match their offer or beat their offer. So they'll increase wages, you'll increase your benefits maybe, say, you know, we have flexible work hours, do something. Fight fire with fire, right? Problem with that is that margins may not support that. Your profit margins may not support that. Kaufman Hall did an analysis that said in 2021, 39% of hospitals would have negative operating margins, no headroom to spend more money on labor. And the average margin for a retail pharmacy is about 1.5% to 2%. This is a pre-tax margin, 1.5% to 2%. This doesn't really address the fundamental issues of just trying to pour money into it when there's not enough supply of these people. And the other thing to remember is that Walmart and Amazon, do they make money? They make a lot of money. Amazon made $38 billion in its last fiscal year. Walmart made $19 billion pre-tax. So it doesn't solve those problems. Here's another one. Let's just crank out more graduates. Get those nursing schools to just get more nurses out there. I was in the introduction of me, my background. I work with a school, UCSF School of Nursing, and I asked Catherine Gillis, the dean, I said, what's the average age of your professors, who are doctorally prepared? Is it about 63? She goes, yeah. So Catherine is facing a situation the next 2, 3, 4 years where the vast majority of her professors actually are going to be retiring. And she says, Ken, what should I do? She's the dean. She's got a PhD and is a brilliant person. But what should I do? That's the problem. This has been something the nursing profession has been talking about for over 10 years. And so as a result of that, if you don't have the professors, you got to turn people away. So as you see here, 80,000 qualified applications were turned away in 2019. The number one reason is lack of nursing faculty. Before the pandemic, we had 155,000 nurses per year graduating from nursing schools, which is pretty good. But the Bureau of Labor Statistics said we needed 200,000. Oops, that's a bit of an issue. Then COVID hit, and all the stress, all those images I showed you earlier, all the stress of nurses, do you think that's going to encourage people or deter people to go into nursing school? I think it's going to deter them. And remember, there's 700,000 near-term resignations and over 1 million retirements coming in 2030. So cranking out more graduates, probably not going to be the solution. How about going overseas? I like this one. So a sixth of all nurses are foreign trained. In California, my state, 30% of the nurses are Filipinos, and I'm Filipino. My parents grew up in the Philippines. And you go, wow, we just get more from the Philippines. So I was at HIMSS in Orlando this year, and there was a booth from the government of the Philippines. So I walk up to the booth and I sit down with them. I said, I need to talk turkey with you guys. How many nurses does the Philippines crank out per year? And they give me this beautiful glossy brochure, and it's 19,000 a year. And not all of those go to the United States. Maybe 10, maybe 12,000 go to the United States, but many go to the Middle East and Europe and other parts of Southeast Asia, Australia, New Zealand, etc. So we don't get all of them, but even if we did, remember the 700,000 who are quitting, remember the 1.1 million who are retiring, remember the 450,000 we're going to be short in just a couple, 3 years. Big challenge. Doesn't really solve the problem. And then pharmacy technicians. So I asked the people from the government of the Philippines about this too. I said, how about pharmacy technicians? Do you have a lot of pharmacy technicians? They go, actually, we don't really have pharmacy technicians in the Philippines. It's a different category of job. We have a lot of pharmacists, but not pharmacy technicians. And the reason is pharmacy technicians in the United States don't make as much money. They make less than half of what the average nurse makes when they start out. And there's not enough margin there, not enough savings there for them to send money back home to their families, right? That's why the nurses are in the United States and other countries. So there's no financial incentive for them. And the licensing requirements and training requirements are different state by state, which causes folks in the Philippines and other countries to go, I'm not so sure I know where I want to live, and it's a little complicated. So they're deterred from considering the United States. So what's the bottom line? Short-term solutions are short-term. They don't address the long-term structural problems, the difficult working conditions. They don't change the fact that you have manual tasks, administrative overhead. They don't change and fix the nursing faculty shortage. They don't deal with the demographic realities that we've just talked about. They actually don't solve those problems. So I was doing a lot of work about demographics, and I was scratching my head thinking, what country has kind of experienced the kinds of demographic challenges the United States is feeling? What country is getting old? Well, it's Japan. Japan is getting really old. So how many of you know the name Kane Tanaka? Does anyone know Kane Tanaka? If you get it, you get a prize if you know this one. Kane, no? Wow. She was in the news in April 19th, in fact, or soon after April 19th. She passed away. She was 119 years old, a Japanese woman, second oldest woman in history that we've been able to verify. There's a woman in France, Jean Calment, who was 122 years old in France. So she's the oldest. But Kane Tanaka died on April 19th at 119. Pretty good. Second place is pretty good. So here's the question. How many people are over 100 years old in Japan today? That's the question. I want you to think about it. I'm going to give you some choices here. Okay? Show of hands. How many of you think there's 1,000 people over 100 years old in Japan? 1,000 people. No one? A few people. Okay, handful. All right. How many of you think it's 5,000 people? A few more. All right. How many of you think it's 10,000 people? About the same. Okay. How many of you think, let's go out on a limb here. How many think it's 50,000 people? 50,000. 50? Okay. About the same. How many of you think it's more than 75,000 people who are 100 years old or more? Not too many. Okay. What's the answer? I feel like Alex Trebek. This is fun. 86,000 people. 86,000 people are over 100 years old in Japan. All right. So that's my proof text, right? Japan's getting older. Now, this is a curve of their population in Japan. They're getting older, and not many babies are being born. And so the population actually is projected to plummet. The younger generations are not having many kids. So in Japan, they have 7 babies for every 1,000 people. 7 for every 1,000 people. That's how the World Health Organization measures these things. You say, well, is that good or bad? Well, okay, give you some benchmarks here. The United States is 12 for every 1,000 people. Last few years, that's kind of our average. And the world is 18.5 for every 1,000 people. So Japan is at 7, the U.S. is at 12, and the worldwide average is 18.5. So it's quite slow. And as you can see in that blue part of that curve there, what's happening? The population is actually contracting. You talk about zero population growth? No, this is negative population growth. It's contracting. And as a result of that, they're going to have an older, obviously an older population. Okay, so McKinsey says, hey, this is a problem. We see these curves too. And if they're advising the government of Japan or the companies in Japan, they're saying, you have an urgent need to do something about this. If you want to maintain your economic growth, if you want to maintain your standard of living, if you want to take care of all these old people, you got to figure out a way to do it with your dwindling labor supplies. And you got to increase productivity. You have to increase productivity to do that. So if you don't do that, it's a big problem. And when we say productivity, how do you get increased productivity? Just not working faster? No, we have to apply technology, digital technology, artificial intelligence, robotics, those kinds of things. That's what McKinsey's telling Japan. They've been doing this for a number of years. And in the case of healthcare, where they have labor shortages like we do, it could really help reduce their costs and then enable them to take care of all these old people as well. So that's McKinsey's recommendation, an increased productivity mandate. So that's a foreign country. You might say, well, that's really different. Well, let's learn a lesson about our own history here in the United States. So the spark of passion ignites the fuel of innovation. That's a Silicon Valley-esque statement if there ever was one. Or necessity is the mother of invention, right? You probably have heard that statement. Henry Ford had a passion. He had a vision. And, you know, it used to be said in the early 70s, we want a chicken in every pot. Henry Ford wanted a car for every American household. He wanted an automobile for every American household. That was his dream. He wanted every man, every woman to have a car. So what did he do? He developed the moving assembly line. And the Model T, and it was December 1st, 2013, the assembly line was started. The first moving assembly line. It was a quantum leap forward for Ford and eventually the entire auto industry. Now, it took, before the moving assembly line, it took 12 hours 12 hours to assemble one Model T. And after they implemented the moving assembly line, guess how long it took? 93 minutes. They went from 12 hours to 93 minutes. So he was able to put this ad out. This is actually, don't envy your neighbor his automobile. You can have a high quality and a low priced car. This is the actual ad that they put in newspapers, right? So it helped him accomplish his dream, his vision. And because of this, he revolutionized not only Ford, but the entire auto industry, not just the United States, but actually worldwide. Everyone uses moving assembly lines. Everyone uses now robotics, right? So it's changed the way cars will be built forever. So here's my path forward. I just kind of knocked down all the short-term solutions, right? They're all Band-Aids. They all don't work really long-term. Accenture, the consulting firm, says intelligent infrastructure is really significant and important for industry to embrace going forward. And for healthcare, it's automation, robotics, data analytics, artificial intelligence, those kinds of things. The three goals of applying intelligent infrastructure are to increase productivity. That's what McKinsey told Japan they have to do, increase productivity, by automating tasks, free workers up to do things that are not manual or labor-intensive, transform jobs to be more analytical and patient-centered. Think about this. How many of you have pharmacy technician roles? Okay, you've got those, but how about an advanced or senior pharmacy technician role that gives them kind of a career path? And by redefining those healthcare career paths, hospitals and health systems, as well as retail pharmacies, could be better at attracting and retaining workers. We won't have as much churn. You know, the churn for pharmacy technicians is about 35%. Think about that. Think about your recruiting and your training costs. So the application of intelligent infrastructure doesn't just meet a short-term need, it actually transforms the industry, and it could be quite significant. Now, lest you think this is pie in the sky, there's no way this will ever happen, it's actually already happening in many ways. I mentioned the Autonomous Pharmacy Advisory Board and the work being done by a number of health systems, but also Walgreens. You may have seen this. This is at the end of March. Walgreens turns to robots to fill prescriptions as pharmacists take on more responsibilities. There's a picture of a robot in a retail pharmacy space, right? And I love the quote from Roz Brewer, the CEO of Walgreens. He says, "We're doing all of this work so that the pharmacist has an easier job so that they can get back to being front and center, building a relationship with that patient and interacting the way they were trained, the work that they love to do." Think about your work. What kind of work do you love to do? Technology could be an enabler for that work, and it could help you in all these different endeavors of recruiting people, training people, retaining people. And that's how we deal with the healthcare labor shortage. So I want to thank you for your attention. To recap, the healthcare labor shortage is big. It is pervasive. It is nationwide, and it's getting worse. It has huge implications for our country, not just for how the healthcare system works, but how we serve and support our patient populations and indeed our nation. And the short-term solutions, while they are expedient and the panic button you press at first, they really aren't the ones that will solve the problem. There is an opportunity through innovation and through technology to really revolutionize and transform pharmacy care in the United States, not just for our jobs, not just for our institutions, but also for our communities, our patients, and the nation as a whole. So I thank you for your attention, and we're going to open up. We have about 10 minutes here for Q&A. Thank you very much.